So imagine you're in a vehicle and you're traveling at just 24 kilometers per hour and you hit a solid wall.
Right, which isn't even that fast, honestly.
Exactly. It's
It,
it's like 15 miles an hour. But the structural crumple zones compress, the airbags deploy, and the skull of the driver comes to this complete instantaneous stop.
but the brain doesn't.
Right. The 3 pounds of, gelatinous tissue inside that skull does not stop, just keeps moving forward at 24 kilometers per hour until it violently collides with the inner ridge of the frontal bone.
Which is just a brutal physical reality.
It is. And today, we are tracking that exact, really unforgiving life cycle of a traumatic brain injury. We're starting from that literal split second of physical impact, and we're diving all the way down into the microscopic, the cellular chaos that it triggers.
Yeah, and tracking those ripples out to the behavioral and emotional aftermath that can surface, decades later.
Decades down the road. So, welcome to the deep dive. To map this progression accurately, we've got a massive stack of clinical literature today, right?
Oh, yeah. We are pulling from foundational medical texts on emergency triage, neuroanatomy, and integrating these really cutting-edge pathology reviews on chronic traumatic encephalopathy, or CTE.
Plus some practical long-term rehabilitation guides that neuropsychologists use.
Right, because the mission for you, the listener, is to build a complete 360-degree clinical picture. We want you to understand not just the physics of how a brain is damaged, but the exact metabolic cascades that dictate recovery.
And the invisible struggles that these patients and their families face every single day long after they leave the hospital.
Exactly.
But before we track the actual physics of that crash, we need to draw a pretty hard line around what we are actually looking at today. Because in the clinical world, acquired brain injury, or ABI, is this big umbrella term.
Right. It covers any brain damage occurring after birth, so it strips away congenital or hereditary conditions entirely.
But ABI actually splits into two vastly different diagnostic paths, non-TBI and TBI.
Yeah, so non-TBI covers damage that originates from an internal physiological failure. So like a ruptured aneurysm, an ischemic stroke blocking an artery, or severe oxygen deprivation from a near drowning.
The insult comes from inside the house, basically.
Exactly, the body's own systems. But traumatic brain injury, TBI, requires an external mechanical force. It's a violent transfer of kinetic energy from the outside world into the biological architecture of the brain.
Like a fall from a ladder, a blast wave, or that 24-kilometer-per-hour car crash.
Right. And if we're dealing strictly with external kinetic energy, the triage doesn't actually begin in the emergency room. It begins with the physics of the impact itself.
Which, why does the specific vector of the crash even matter to a neurosurgeon? If a patient's brain is bleeding, isn't the priority just to stop the bleeding? Like whether they hit a windshield or fell off a bike?
You'd think so, but no. Knowing the biomechanical forces dictates entirely what kind of damage the doctor is looking for, long before they even order a CT scan.
Oh, interesting.
Yeah, we analyze this through the kinematics of TBI. And kinematics focuses purely on the motion of objects, so the skull and the brain moving through three-dimensional space, without necessarily factoring in the mass or the forces causing the motion.
Okay.
Brain injury begins with the mechanical deformation of the brain parenchyma, which is the functional tissue.
But wait, the skull is a rigid, bony vault. For the internal tissue to deform, wouldn't the skull itself have to fail first?
Well, not necessarily fail in terms of shattering,
Yeah.
but it does deform. Bone actually has an elastic limit. During a severe impact, the skull physically bends inward.
It actually bends. Wow.
Yeah, and this introduces a really critical engineering concept that the biomechanical literature emphasizes, which is stress concentration.
Oh, this is the frozen lake scenario from the sources.
Exactly. Walk me through it.
Okay, so imagine you walk out onto a frozen lake wearing snowshoes. Your mass is distributed evenly across this wide surface area. The cohesive strength of the ice holds your weight perfectly fine. But if you walk onto that exact same ice wearing stiletto heels, the exact same downward force is suddenly concentrated into, like, a fraction of a square inch.
The localized stress violently exceeds the ice's cohesive strength.
Right, and the heel punches straight through.
And when we map that concept onto the human skull, a broad impact might just cause that transient bending, but a localized impact, say, falling and hitting the corner of a brick, creates massive stress concentration.
The skull fractures.
Right, driving bone fragments directly into the meninges. But even if the skull remains perfectly intact, the brain inside is still subjected to acceleration forces that literally tear it apart from the inside.
And the clinical literature divides these forces into linear and rotational acceleration, right?
Exactly.
Linear seems straightforward, just a direct strike along a single axis.
Yeah, purely linear impact usually results in a focal injury. The damage is highly compartmentalized. The kinetic energy basically drives the brain tissue directly into the skull at the exact site of impact.
Creating a localized bruise, essentially.
Right? A zone of contusion and vascular tearing.
But wait, if linear forces cause that focal damage, why does the literature point to rotational acceleration as being so much more devastating? If your head twists violently in a rollover crash, your brain is still just hitting the inside of the skull, isn't it?
No, that's the thing. It's not just hitting the skull, it's tearing its own internal architecture apart.
Oh, wow.
Yeah. You have to remember, the brain is not a perfectly homogeneous sphere floating freely in fluid. It is tethered.
Right, the brainstem.
Exactly. At the base of the skull, the brainstem exits through the foramen magnum to connect to your spinal cord. So when a glancing blow violently twists the head, the skull rotates instantly. But the brain, because of its own inertia and its gelatinous consistency, it lags behind.
So it rotates around that fixed axis of the brainstem.
Yes.
It's like twisting the stem of an apple, but the inside of the apple is made of like layers of contrasting gelatin.
That is the perfect analogy, because that contrast in layers is the exact mechanism of destruction. The brain is made of gray matter, the cell bodies on the outer cortex, and white matter, which are the heavily myelinated axonal tracts running deep inside.
And they have completely different densities.
Exactly. So when the brain twists, the denser gray matter and the lighter white matter accelerate and decelerate at totally different rates.
Oh man, so they're moving at different speeds right next to each other.
Yes, and this creates massive shearing strain right at the boundaries where those tissues meet. It doesn't just create a single bruise. It causes diffuse microscopic tearing of millions of neural connections and tiny blood vessels throughout the entire organ.
That's terrifying. But if the physics of stress concentration and rotational shearing are this well documented,
Yeah.
why hasn't biomechanical engineering just solved this? I mean, we have supercomputers that model fluid dynamics in jet engines. Shouldn't we be able to engineer a car cabin or a helmet that mitigates these exact kinematic thresholds?
You would think so. But the bottleneck isn't the math or the modeling. It's a fundamental lack of reliable human data.
What do you mean?
Well, we cannot ethically instrument a living human being with intracranial pressure sensors, put them in a car, and subject them to a high-speed rotational collision just to see when their memory centers fail.
Right, obviously. So where does the safety standard data even come from? Like the Wayne State tolerance curve mentioned in the sources?
Historically, that foundational biomechanical data came from dropping embalmed cadaver heads down elevator shafts.
Wait, really? Elevator shafts?
Yeah, that, along with comparative animal testing and scaling up non-injurious volunteer data from really low-level impacts. The Wayne State tolerance curve basically graphs effective acceleration against impact duration to establish a threshold for severe injury.
But dropping a cadaver head only gives you structural failure points, right? It just tells you how many G-forces it takes to crack the bone or cause a macroscopic bleed. But structural data tells you absolutely nothing about consciousness. Like, a fractured cadaver skull can't tell you that it suddenly suffers from clinical depression or that it just lost the ability to regulate its anger.
Precisely. And that is the massive limitation we face. We are attempting to protect the most complex biological supercomputer in the universe by crash testing its plastic casing.
Wow.
We know exactly what breaks the container, but we have incredibly limited direct data on the precise mechanical thresholds that cause a microscopic axonal tract to misfire a decade later.
That immediately reframes the stakes in the emergency room, doesn't it? Because if testing on cadavers leaves this huge functional blind spot, the ER team receiving a comatose patient from a rollover crash has to bridge that gap instantly.
They really do.
I mean, the ambulance door's open, the patient is unconscious. How do the doctors quantify the functional damage of those rotational forces when structural imaging hasn't even happened yet?
They rely on rapid, standardized clinical observation. The immediate mandate in that first hour, the golden hour of trauma, is to establish clinical stability, secure an airway, and categorize the depth of the neurological deficit.
And the universal gold standard for this is the Glasgow Coma Scale, or the GCS.
Right. It provides a quantifiable, reproducible measure of impairment within the first 24 hours.
So the GCS scores a patient from 3 to 15 based on 3 specific criteria, right? best eye-opening, best verbal response, and best motor response.
Yes.
But why those three specifically? Like, why not check reflexes or pupil dilation as the primary scoring metric?
Because eye-opening verbal output and motor response map perfectly to different anatomical tiers of the nervous system.
Oh, I see.
Yeah. Spontaneous eye-opening indicates that the brainstem's reticular activating system is still functioning. Meaningful verbal response requires a highly complex orchestration of the cerebral cortex, specifically the frontal and temporal lobes.
And motor response.
That tests the integrity of the descending tracks, going from the cortex down through the midbrain and the spinal cord.
So it's basically a top-to-bottom systems check.
Exactly. If a patient cannot track a light with their eyes and exhibits abnormal physical posturing, the physician instantly knows the shearing damage has cascaded deep into the midbrain.
Okay, let's map these scores to clinical reality. A patient comes in after a bad tackle on a football field. They're confused, but they're talking.
So that falls under mild TBI, which is categorized by a GCS score of 13 to 15. Clinically, this is synonymous with a concussion. There might be an alteration in mental state, maybe brief post-traumatic amnesia, or a transient loss of consciousness lasting less than 30 minutes.
But I want to be clear here. The label mild is purely a triage classification for survival, right? It's not a description of their long-term prognosis. Because a mild TBI can still completely derail a person's life with chronic headaches, light sensitivity, cognitive fatigue.
Absolutely. If those symptoms persist for months, the diagnosis evolves into post-concussion syndrome. But in the ER context, mild just means the patient is structurally stable right now.
Okay. And a moderate TBI.
That's a GCS of 9 to 12. It usually involves loss of consciousness, stretching beyond 30 minutes, significant confusion, and often physical focal deficits, like maybe weakness on one side of their body.
And then severe TBI is a GCS of 8 or less. And there's that saying in emergency medicine, right? Less than 8, intubate.
Right. At a GCS of 8, the patient is essentially in a coma. The brain has lost the ability to protect its own airway.
Meaning they could start breathing or aspirate.
Exactly. This demands immediate mechanical ventilation, rapid transfer to the neuro-ICU, and usually the surgical placement of an intracranial pressure monitor.
Which is a probe drilled directly through the skull.
Yes, right into the brain to measure swelling in real time.
Okay, so while the trauma team is securing the airway, the imaging team is moving in. And the literature heavily emphasizes the non-contrast CT scan as the absolute workhorse of acute head trauma. But why a CT over an MRI? An MRI gives a much more detailed picture of soft tissue, doesn't it?
It does, but it comes down to speed and specific sensitivity.
Yeah.
An MRI can take 45 minutes and requires the patient to be perfectly still.
Which is often impossible in a chaotic trauma setting.
Exactly.
Yeah.
The CT scan takes seconds.
Uh-huh.
But more importantly, a non-contrast CT is incredibly sensitive to hyperdense acute blood.
Fresh blood.
Right. Fresh blood pooling in the brain from a torn artery shows up as bright, glaring white against the darker gray matter. The neurosurgeon needs to know instantly if there's an epidural hematoma.
Which is a rapidly expanding pocket of arterial blood.
Yes, compressing the brain. That requires an emergency craniotomy right then and there to evacuate the blood and relieve the pressure.
But a CT scan only captures the macro-level destruction, right? It catches the major floods. What happens when a patient is comatose, clearly highly symptomatic, but the CT scan comes back completely clear?
And that highlights the insidious nature of rotational acceleration. Diffuse axonal injury, that microscopic shearing we discussed, it often does not show up on an initial CT scan because there's no massive localized hemorrhage.
Just millions of tiny microscopic tears.
Right. And this diagnostic gap is exactly why the clinical field is rapidly adopting protein biomarkers. We're moving beyond just imaging and we're looking at the blood.
Right, the biomarker GFAP, glial fibrillary acidic protein.
You got it. Astrocytes, which are these star-shaped support cells in the brain, contain really high concentrations of GFP. When mechanical shearing forces tear these cells open, they spill GFP into the extracellular space.
And it eventually crosses the blood-brain barrier into the general blood circulation.
Exactly. So a simple blood draw in the ER can detect these elevated GFAP levels. It basically acts as a molecular distress signal, proving that severe cellular destruction has occurred, even when the radiological scans look pristine.
So whether the doctors are looking at a glaring white contusion on a CT scan or elevated GFAP in a blood test, they're trying to map the anatomical nature of the damage. Let's look at the classic focal injury we touched on earlier, the coup contre coup.
Right, the hallmark of sudden linear deceleration.
Hmm.
Imagine a cyclist thrown over the handlebars, striking their forehead directly on the asphalt.
Okay.
The primary impact of the frontal bone is the coup injury. The skull stops instantly, and the brain smashes into the anterior interior of the skull.
But because the brain is suspended in cerebrospinal fluid, it rebounds.
Right. It violently recoils in the exact opposite direction and strikes the occipital bone at the back of the skull. That secondary impact is the contra coup.
So you end up with two distinct zones of bruising on opposite poles of the brain from one single directional impact. But the clinical texts point out a really fascinating anatomical detail about where these contusions actually form. They don't just appear as uniform bruises on the smooth outer surface of the brain.
No, they don't.
They preferentially form on the crests of the gyri, the raised ridges of the brain's folds, particularly in the frontal and temporal lobes. Why specifically there?
You have to look at the base of the skull, the cranial vault where the brain actually sits. The inner surface of the skull cap. The top part might be relatively smooth, but the floor and the anterior cranial fossa and the petrous ridge of the temporal bone is incredibly jagged.
Jagged bone.
Yeah, it's characterized by sharp bony ridges and rough protuberances. So when the brain accelerates and decelerates, the soft tissue of the inferior frontal lobes and the anterior temporal lobes literally grates against this bony sandpaper.
Ouch.
Yeah. The crests of the gyri are physically shredded by the skull's own internal architecture.
That is awful. Contrast that rough, grinding focal damage with the mechanism of diffuse axonal injury, DAI, from a high-speed collision. We know DAI targets the junctions between gray and white matter, but the literature specifically highlights the corpus callosum as a primary casualty.
Yes, it does.
But if the corpus callosum sits dead center in the brain, buried way deep beneath the hemispheres, shouldn't it be the most protected structure? Why is it so vulnerable?
Actually, its location is precisely its vulnerability. The corpus callosum is this massive, dense superhighway of over 200 million heavily myelinated nerve fibers connecting the left and right hemispheres.
Okay.
Because it's such a rigid, dense structure sitting exactly on the midline, when the lighter outer hemispheres twist and rotate around that central axis during a violent rotational impact, the corpus callosum absorbs an immense amount of torsional strain.
Oh, I see. It's anchoring the twist.
Exactly. It twists, and the microscopic axons running all through it just tear.
So the gyri are scraped against bone, the corpus callosum is wrung out like a wet towel, and the cell membranes are sheared open. The physical event is over. And this brings us to a really harsh clinical reality that underpins all of neurotrauma. There is absolutely no medical treatment for primary brain injury.
None. You cannot untear a white matter tract. You cannot unbruise the frontal lobe.
The primary injury is just that kinetic destruction occurring at the exact millisecond of impact. It's done. Permanent.
Exactly. So the entire focus of the trauma team, the reason for the intubation, the CT scans, the invasive monitoring during those first 72 hours is solely to mitigate the secondary injury.
Let's define secondary injury, because from what I'm reading, this is where the actual clinical battle is fought.
Secondary brain injury refers to the highly complex cascade of pathological and biochemical processes that are unleashed by the primary trauma.
So the primary impact sets the fire, and the secondary injury is the ensuing inferno.
That's a great way to put it. It evolves over minutes, days, and weeks, and it causes the dysfunction and death of millions of neurons that were actually perfectly healthy at the moment of the crash.
And the absolute paramount objective of the ICU during this time is preventing hypoperfusion, low blood flow.
Right.
Why is the injured brain so exquisitely sensitive to a drop in blood pressure?
When the brain sustains physical trauma, it immediately enters a hypermetabolic state. The surviving cells are thrown into crisis mode. They need massive amounts of energy to run ion pumps, repair damaged membranes, and clear out cellular debris.
So the brain's demand for glucose and oxygen just skyrockets.
Exactly. And at the exact moment it needs maximum fuel, it becomes incredibly vulnerable to ischemia, which is a restriction in blood supply.
There's a terrifying reality in trauma care cited in the sources.
Mm-hmm.
A single documented drop in systolic blood pressure below 90 millimeters of mercury, even for just a few minutes, drastically increases the mortality rate and worsens the cognitive outcome of a TBI patient.
Right, because consider the reality of a multi-system trauma. The patient didn't just hit their head, maybe they shattered their pelvis and ruptured their spleen. They're hemorrhaging internally, so their systemic blood pressure plummets.
And usually, doesn't the brain have a way to protect itself from that?
Under normal conditions, yes. The brain has an autoregulatory system that dilates cerebral blood vessels to maintain flow, even when systemic pressure drops. But a severe TBI often breaks that exact autoregulatory mechanism.
So the brain loses its ability to protect its own blood supply.
Exactly. So as the patient bleeds into their abdomen, the pressure driving blood up into the hypermetabolic injured brain just collapses.
Which areas get hit hardest?
The areas most susceptible are the watershed regions, which are the areas at the very distal ends of the arterial supply lines, like the high parietal lobes, and the hippocampus, which is densely packed with highly active neurons critical for memory formation.
Because they're at the end of the hose, basically.
Right. If the water pressure drops, those are the first zones to dry up and undergo ischemic death. You're effectively starving a patient who is actively bleeding out.
Wow. So all those beeping monitors, the vasopressor medications pushing the blood pressure up, the ventilators pushing oxygen in this huge macro-level desperate intervention is entirely in service of a microscopic war.
Absolutely.
We need to leave the ICU now, zoom in 1,000 times, and look at the actual cellular battlefield. How does a mechanical stretch force trigger the death of a single microscopic neuron?
This is the metabolic cascade. And honestly, it's arguably the most complex pathological phenomenon in the human body. To understand why a brain struggles so violently to heal, you have to look at the excitotoxicity loop.
Okay, let's track the exact sequence of this loop for the listener. It starts with the mechanical deformation, the shearing force we discussed. The axon is physically stretched.
And that violent stretching causes microscopic structural failures in the cell membrane, which is called the axonema. This is known as mechanoporation.
Poration, like pores.
Right. Tiny pores, or holes, are quite literally ripped into the lipid bilayer of the cell.
So the hull of the cell is breached.
Exactly. Once the membrane is compromised, the intracellular contents begin to leak out. And this triggers the first major biochemical domino, the massive, unregulated release of glutamate.
Glutamate is a neurotransmitter, right?
It is the primary excitatory neurotransmitter in the brain. Normally, it's very tightly controlled. It's stored in vesicles and released in precise, minute quantities to transmit electrical signals between neurons.
But the structural damage causes a toxic spill. Glutamate just floods the extracellular space.
Yes. And this excessive glutamate binds indiscriminately to receptors on all the neighboring neurons. Specifically, it heavily overstimulates the NMDA receptors.
And what do NMDA receptors do?
They act as a massive gated channel on the cell membrane. Under normal conditions, they open briefly to let ions in, but battered by this immense glutamate flood, the gates are locked open.
Which initiates the ionic crisis.
Right. The cell works hard to maintain a very strict electrochemical gradient. It keeps a high concentration of sodium and calcium outside the cell and potassium inside.
But with the NMDA gates locked open,
That gradient collapses entirely. Potassium rushes out, and there is a lethal, unregulated influx of sodium and calcium roaring into the cell.
now calcium isn't just an inert mineral here. Inside a neuron, it's a critical signaling molecule. A massive influx of calcium is basically like a chemical alarm bell, triggering every single emergency protocol in the cell simultaneously, right?
Exactly. The neuron immediately recognizes these toxic levels of intracellular calcium and sodium, and it desperately tries to bail them out to restore the gradient.
How does it do that?
It relies on sodium-potassium pumps and calcium AT passes. These pumps require ATP, which is the fundamental energy currency of the cell. But because the flood of ions is so massive, these pumps have to go into absolute overdrive.
Okay, the submarine analogy from the source has really clicked for me here. Imagine a submarine that has just taken a depth charge hit. The hull is breached. That's the mechanoporation. Ocean water is flooding into the engine room. The water is the calcium.
Perfect.
The crew immediately engages the emergency bilge pumps to push the water back out into the sea. And those bilge pumps are the ATP-dependent ion pumps.
And those pumps require massive amounts of power to run at that speed.
Exactly. They're running at maximum capacity, burning through the submarine's diesel fuel, the ATP, at a completely unsustainable rate. They are desperately trying to outpace the flood, but the breach in the hull is just too large.
So what happens?
Eventually, the generators run out of fuel. The bilge pumps stutter and die. And the water, the calcium, keeps rising until it swallows the engine room entirely and the sub sinks.
And the engine room in this biological scenario is the mitochondrion. The mitochondria are the power plants generating the ATP. As they try to meet this impossible energy demand while simultaneously buffering the toxic calcium load themselves, they undergo mitochondrial permeability transition.
Meaning their walls break down.
Yes, they fail entirely. The fuel runs out.
And the cell is defenseless. So what does all that high calcium do when the pumps finally stop?
It activates destructive intracellular enzymes, specifically proteases like calpains and caspases. You can visualize calpains as microscopic molecular scissors.
Oh, man.
Yeah. Once activated by the high calcium, they begin indiscriminately slicing up the cell's internal scaffolding, the cytoskeleton.
The cell is quite literally digesting its own structural integrity from the inside out. That is horrific.
It is. And this metabolic catastrophe leads to one of two outcomes. If the energy depletion is absolute and rapid, the cell undergoes necrosis.
Which is?
It's a messy, unregulated rupture where the cell bursts and spills its toxic inflammatory contents into the surrounding tissue, which then damages even more neighboring cells.
And the second outcome?
If the cell retains just enough ATP to initiate a programmed sequence, it undergoes apoptosis. This is a controlled cellular suicide where it packages itself up neatly for disposal.
But either way, the cell is gone. And this invisible molecular death leaves permanent physical scars on the architecture of the brain. Like, when we think of a scraped knee, the tissue dies, scabs over, and new skin cells regenerate. The skin heals flawlessly.
Right.
But the brain does not regenerate parenchyma, does it?
No, it doesn't. When you have widespread necrosis following a TBI, the body's immune system, the macrophages, eventually clear away the dead cellular debris. But because neurons don't regenerate to fill the void, the death leaves behind an actual physical cavity.
A literal hole in the brain tissue.
Yes.
But nature abhors a vacuum. How does the brain patch a physical cavity if it can't grow new neurons?
Through a process called reactive gliosis. Astrocytes and microglia, the inflammatory support cells, migrate to the edge of the cavity and proliferate. They weave a dense, fibrous wall of scar tissue around the damage.
But that scar tissue isn't functional, is it? It doesn't transmit electrical signals or store memories.
No, it's functionally inert. It is merely a structural patch to seal off the damage. And this gliosis permanently alters the physical topology of the brain. It disrupts the highly complex three-dimensional neural networks that dictate cognition, impulse control, and personality.
Because the pathway that used to rapidly connect, say, a thought to a physical action is now blocked by a literal dense wall of fibrous astrocytes.
Exactly. The signal has to find a new, less efficient detour, or it fails entirely.
So eventually, the acute metabolic fire, the acidotoxic loop, the glutamate flood, the failing mitochondria, it burns out, the patient stabilizes, they leave the hospital. But the embers of that fire, the altered architecture, and the dense scar tissue, they continue to smolder.
Yes, they do.
Which brings us to the chronic phase of brain injury. What happens decades after a severe trauma or after a lifetime of repetitive subconcussive impacts? Let's step into the long shadow of TBI and examine the neurodegenerative legacy. Chronic traumatic encephalopathy.
CTE. It really dominates the modern neurotrauma conversation, heavily associated with American football players and military veterans. But the pathological footprint of this disease was actually documented nearly a century ago.
Yeah, in 1928, a forensic pathologist in New Jersey, Dr. Harrison Martlin, published a landmark paper in the Journal of the American Medical Association. But he wasn't looking at football players, he was examining prize fighters.
Right. Martlin identified a highly specific progressive neuropsychiatric syndrome in boxers who had absorbed thousands of subconcussive blows over their careers, or who had suffered a few massive knockouts.
And the terminology he used in 1928 really highlights exactly how society viewed these men at the time. He didn't use sophisticated neurological terms.
No, he didn't.
He documented them as acting cuckoo, slug nutty, or suffering from punch-drunk syndrome. They walked with unsteady, broad-based gaits, exhibited severe memory loss, and slurred their speech.
They appeared intoxicated, even when they were perfectly sober. The clinical nomenclature obviously evolved over the decades, moving from punch-drunk to dementia pugilistica, and finally coalescing into chronic traumatic encephalopathy.
But Martlin was kind of a visionary, right?
He was, because without the aid of modern electron microscopy, he correctly deduced the mechanism. He posited that the repetitive mechanical blows were causing microscopic ring hemorrhages deep in the cerebral tissue, setting off a latent degenerative cascade.
He knew the physical trauma was triggering a chronic biological decay. Fast forward to modern neuropathology, and the literature reveals a terrifying truth about just how long that decay lasts. We discussed neuroinflammation as a short-term response to the acute injury, but modern studies have found activated inflammatory microglia swarming in a patient's brain tissue up to 17 years after a single traumatic brain injury.
17 years.
That is staggering.
It's 17 years of continuous, smoldering inflammation. The brain essentially never turns off the alarm bells from that initial mechanical impact.
The immune system just remains in this hyper-vigilant, destructive state, slowly degrading healthy tissue.
Right. And this chronic inflammation is intricately tied to the defining microscopic hallmark of CTE.
And this is exactly where diagnostics hit a wall, isn't it? If a 50-year-old former athlete walks into a clinic with severe mood swings and memory loss, why can't a neurologist just put them in an MRI machine and officially diagnose them with CTE?
Because CTE cannot be definitively diagnosed in a living patient. It strictly requires a post-mortem neuropathological examination.
An autopsy.
Yes. Standard MRIs and CT scans visualize macrostructures. They look for tumors, strokes, or large cavities. But the hallmark of CTE is molecular. It is the insidious accumulation of hyperphosphorylated tau protein.
Okay, let's examine tau because it's so critical. In a healthy neuron, tau is essential, right?
Very essential. It acts as the cross ties on a railroad track. It binds and stabilizes the microtubules that give the long axon its physical structure and act as the transport highway for nutrients.
But the mechanical trauma, the shearing forces, and that chronic 17-year inflammatory environment cause the tau protein to become chemically altered, hyperphosphorylated.
And when that happens, it detaches from the microtubules. The railroad tracks essentially collapse and the dying axon starves.
And what happens to the detached tau?
The detached tau proteins misfold and clump together, forming highly toxic, insoluble neurofibrillary tangles.
But these tangles don't just appear randomly scattered across the brain. Pathologists look for a highly specific spatial pattern to confirm CTE. Where do these toxic proteins cluster?
They specifically aggregate around the microvasculature, the tiny blood vessels, predominantly at the very depths of the brain's folds, the sulci.
The sulcal depths. Connect that back to the biomechanics we talked about earlier. Why the sulcal depths?
It directly correlates to the physics of stress concentration. When the brain tissue violently compresses and stretches during an impact, mathematical models show that the mechanical strain is highest precisely at the sulcal depths.
So it's physically taking the brunt of the force.
Exactly. This massive localized strain causes a micro-rupture of the blood-brain barrier at those specific blood vessels. This allows inflammatory macromolecules from the bloodstream to leak into the brain tissue, serving as the epicenter for the toxic tau buildup.
Wow. It's like a microscopic weed taking root at the exact point of maximum physical stress. And over decades, this toxic tau pathology spreads outward from the sulcal depths, infecting neighboring tissue.
And the microscopic destruction eventually manifests as gross anatomical decay. The brain quite literally begins to shrink.
Shrink.
Yes, we observe profound regional atrophy. The frontal and temporal lobes lose massive amounts of volume. Because the dense brain tissue is shrinking and dying, the natural fluid-filled spaces inside the brain, the lateral ventricles, must physically expand to fill the void inside the rigid skull.
Like blowing up a balloon inside a box to take up the empty space.
Exactly. This massive dilation is called ventriculomegaly. Pathologists also document severe thinning of the corpus callosum, the structure that absorbed all that rotational torsion we discussed earlier, and the destruction of the mammillary bodies, which are tiny structures on the floor of the brain essential for episodic memory. The hardware is physically dissolving.
But, an autopsy report only details the structural decay. How does a dilated ventricle or a microscopic tau tangle translate to a human life? How does it alter the day-to-day reality of the patient and their family?
To understand the human cost, we have to map that specific anatomical decay directly onto behavior. When the frontal lobe atrophies, the patient loses their executive function. When the temporal lobe degrades, memory and emotional regulation fail.
The psychological symptoms outlined in the clinical literature are terrifying because they really dismantle the fundamental identity of the patient. Like, memory deficits and Parkinsonian tremors are devastating, obviously, but it is the behavioral shifts that truly shatter families.
Patients develop profound paranoia, erratic mood swings, and a total loss of impulse control.
And a critical symptom we see frequently in chronic TBI and CTE cases is emotional lability.
Yes, the patient's emotional regulatory thermostat is effectively shattered.
What does emotional ability look like at the dinner table, for instance?
It manifests as sudden, intense, and entirely context-inappropriate emotional responses. A patient might, drop a fork on the floor and instantly fly into a blinding, destructive rage, or conversely, they might attend a somber funeral and begin laughing hysterically.
And it's crucial to understand here that they don't actually find the funeral humorous, do they?
No, not at all. It is a pure neurological misfire. The frontal lobe pathways required to inhibit inappropriate responses and regulate emotional output have been physically destroyed by the shearing forces and the tau tangles.
So they feel the grief, but their brain outputs laughter.
Exactly. The patient may feel a deep sense of grief, but the damaged circuitry forces the physical response of laughter. Combined with severe impulsivity, this creates an impossibly volatile environment for the spouse and children trying to care for them.
And layered on top of all that volatility is the crushing weight of depression. TBI survivors are 2 to 5 times more likely to develop clinical depression compared to the general population. And there is a deeply cruel irony in how this depression impacts their recovery.
Right, because depression is not merely profound sadness. It's characterized by deep apathy, psychomotor retardation, and chronic fatigue.
And what is the absolute prerequisite for a patient to engage in the grueling, repetitive, frustrating work of cognitive and physical rehabilitation?
Motivation,
Very true.
drive.
Exactly.
The organic brain damage directly causes the neurochemical depression, and the depression drains the exact psychological reservoir the patient desperately needs to engage in the therapy required to adapt to the brain damage.
It is a devastating feedback loop.
Truly devastating.
Is there a predictable timeline for these families? Like if a 30-year-old suffers a severe TBI, can a neurologist chart a map and say, expect the aggressive outbursts in year 3 and the profound memory loss in year 10?
Unfortunately, no. The clinical trajectories are notoriously unpredictable. The pathology does not move in a straight line. Some behavioral symptoms, like impulsivity, might surface immediately after the trauma and then slowly fade as the brain leverages neuroplasticity to route around the damaged scar tissue.
But other symptoms lie in wait.
Exactly. A patient might function relatively normally for 2 decades, only to develop severe paranoia and motor deficits in their 50s.
It's like a time bomb.
The underlying neurodegenerative tauopathy smolders below the clinical threshold for years until enough structural reserve is destroyed, and the symptoms suddenly cascade into the patient's daily life.
And this inherent unpredictability shifts an immense lifelong burden onto the patient's family. The rehabilitation guides emphasize that the family serves as the ultimate safety net. But how does a spouse transition from being a romantic partner to a full-time neurological caregiver?
It requires a massive paradigm shift. The family must transition out of the acute medical emergency mindset they adopted in the ICU and accept that they're now managing a chronic, lifelong behavioral condition.
That's a hard pill to swallow.
It is. The first and often most difficult step is extensive psychoeducation.
The family has to internalize that the sudden rage or the cruel, impulsive comment is a symptom of organic brain damage, not intentional emotional abuse. The brain is misfiring.
And that cognitive reframing is absolutely essential for the caregiver's own psychological survival. Practically, the literature stresses the implementation of rigid, predictable external routines.
Why is routine so important?
When a patient's internal cognitive structure, their ability to sequence tasks, remember appointments, or manage time is destroyed, the external environment must provide that structure. A chaotic, unpredictable home environment spikes the patient's anxiety, which immediately triggers the emotional lability and aggressive outbursts.
And when those outbursts occur, the clinical guidance actually leans heavily away from just sedating the patient with medication.
Right. Pharmacological interventions are utilized for severe depression or highly dangerous aggression, but psychoactive medications often carry cognitive side effects that can further cloud an already compromised brain.
So what do they do instead?
The emphasis is heavily placed on behavioral interventions. Caregivers work with neuropsychologists to identify the specific environmental triggers that spark a rage episode, modify the home environment to eliminate those triggers, and develop de-escalation strategies that don't rely on chemical restraints.
It sounds like an exhausting daily process of psychological adaptation.
It really is. You are forced to mourn the continuous loss of the person as they used to be, while simultaneously learning how to communicate with and care for the person they are slowly becoming.
Wow. We have tracked an immense clinical journey today.
We really have. We started with the unyielding physics of kinematics. We examined how the specific vector of a 24-kilometer-per-hour impact dictates whether the brain suffers a focal contusion against the rough petrous ridge or diffuse microscopic tearing of the corpus callosum due to rotational shearing.
We stood in the emergency room, tracking the desperate race against hypoperfusion. We saw how a single drop in blood pressure can starve a hypermetabolic brain, and how the Glasgow Coma Scale bridges the gap between cadaveric physics and living consciousness.
And then we zoomed into the microscopic battlefield to witness the excitotoxic loop. the devastating membrane paration, the toxic glutamate flood, the desperate exhaustion of the cell's ATP, and the final structural decay, leaving behind permanent cavities patched by fibrosclerosis.
And finally, we explored the long shadow of the injury. We tracked Dr. Martlin's punch-drunk boxers to modern CTE pathology, examining how microscopic tau tangles at the depths of the sulci eventually collapse the brain's architecture, manifesting years later as devastating emotional levity and profound depression.
It is a stark, comprehensive picture of trauma. But the clinical literature leaves us with one final, provocative concept that fundamentally challenges how we view even a mild concussion.
Yeah, this part of the reading really stuck with me. It's known as the cognitive reserve hypothesis.
Right. We usually conceptualize a TBI as a discrete event. You suffer an impact, you endure a period of acute symptoms, you heal to your maximum medical improvement, and the event is over. The timeline resets.
The cognitive reserve hypothesis shatters that timeline. It posits that every human has a neurological bank account, a cognitive reserve built through education, genetics, and healthy neural networks.
And this reserve acts as a robust buffer against the natural, inevitable cognitive decline that accompanies normal aging. If you have a high reserve, your brain can sustain the microscopic decay of aging for decades before you ever show clinical symptoms of dementia.
But a traumatic brain injury acts as a massive, permanent withdrawal from that account.
Exactly. Even if the acute symptoms of a concussion fully resolve within a month, the structural damage, the lost neurons, the severed white matter tracts, permanently lowers your total cognitive reserve.
The injury heals, but the buffer is gone.
Yes. The trajectory of your brain's normal aging process is fundamentally altered.
Which leaves us with a lingering, deeply unsettling question regarding the long-term physics of trauma. If a biomechanical impact permanently drains your cognitive bank account today, how does a single concussion in your 20s dictate the exact timeline of who you will become in your 70s?
Does surviving a crash today silently accelerate the clock on your own mind?
It frames every impact, every single subconcussive blow, not just as a temporary injury, but as a permanent subtraction from your neurological future. The initial transfer of kinetic energy might be over in a millisecond, but the ripples in those diagnostic waters quite literally last a lifetime.
They do.
Thank you for joining us on this intense, complex deep dive. Keep questioning the physics of the world around you, keep pushing for a deeper understanding of the science, and we will see you on the next deep dive.